So welcome to our webinar all about calcinosis. Presenting is Ariane Herrick. She's a professor of rheumatology at the University of Manchester. Her main clinical and research interests are Raynaud's phenomenon, systemic sclerosis spectrum disorders, and assessment of the microvasculature, including capillaroscopy. She's a past president of the Scleroderma Clinical Trials Consortium, a co-chair of the EULAR study group Microcirculation in Rheumatic Diseases, and a vice president of Scleroderma and Raynaud's UK. So for this webinar, we'll be having a presentation with Dr. Herrick and then a Q&A session at the end. So if you have any questions, there's a Q&A box down the bottom of your screen. You can just pop them in there. You can let us know whether you want them to be anonymous or not. Please don't put anything too personal in there because this webinar is recorded and we will be putting it on YouTube afterwards. We won't be able to answer anything too kind of personal, too diagnosis based, but please do let us know your questions. So without any further ado, I will hand over to Dr. Herrick.
Yeah, well, thank you so much, Lucia, to you and your colleagues for the introduction. And I'm delighted to give this webinar on calcinosis because, as so many of you here know, this is a tremendous clinical problem, or at least it can be, in people with scleroderma, and it's good to be able to have a discussion about it. So I'm going to cover the different points on the slide here. I'll just run through them quickly and then expand on the individual points. I'm going to talk about what calcinosis is, how common is it, and whereabouts does it occur, reasons for calcinosis occurring. Why do some people and not others with scleroderma develop calcinosis? What is the impact of calcinosis on the individual? How do we measure it and how do we treat it? So I'm going to start off by talking about what calcinosis is and how common it is. So here's an example of calcinosis of the thumb. And many of you will be only too familiar with this sort of problem. The thumb is a common site for calcinosis, and essentially calcinosis means deposition of calcium-containing salts within or beneath the skin. And you can actually see these white, slightly shiny crystals, which are visible here through the skin. Sometimes it's not so obvious, but this example, it is very obvious. And this is what happens, that you get these lumps forming underneath the skin. So here's an example of which I'm sorry that you weren't seeing for the first time around, of calcinosis of the thumb. When you see these lumps beneath the skin, and in this particular example, you can actually see the calcium beneath the skin. That doesn't always happen, but has on this occasion. Next. Okay, so calcinosis in people with scleroderma is common. It's said to affect between 25 and 40% of patients. And that would certainly be our experience from the cohort attending Salford. I think the reason why numbers vary is because it really depends how carefully you look for it. And if, for example, you were to X-ray everyone's hands of people with scleroderma, then you would actually find small calcium lumps in individuals who weren't aware of them, because sometimes calcinosis can be subclinical. So it does depend how carefully you look. But anything between 25% to 40% of people probably have calcinosis to some extent. And the fact that calcinosis is common in people with scleroderma is a little bit reflected by the fact that it's a C in the term crest. And crest is the old term, as it were, for the limited cutaneous type of scleroderma. And many of you will know that there are two main types of systemic sclerosis or scleroderma. There's the limited cutaneous type and the diffuse cutaneous type. And crest was a slightly confusing term, but it really just is an acronym for 5 of the clinical features of scleroderma. And one of the reasons why some of us don't like the term so much now is that you can get all the features of crest in the diffuse type of scleroderma. So it's not really so useful in separating out the two subtypes. And you can actually get calcinosis in diffuse cutaneous scleroderma. It's not just patients with limited cutaneous scleroderma. And calcinosis tends to occur mainly over pressure points. So that is the fingers, and particularly the thumbs and index fingers, as we saw on the slide earlier, over the elbows and the knees. And sometimes it can, however, occur in other areas. For example, it can occur in the neck or in other parts of the spine. Okay, next. And I'm very grateful to many of you who completed the SR-UK survey, which ran a bit over a year ago now. We're very grateful to SR-UK for sending around this survey, which was in a way to benchmark the problem of calcinosis for trying to really make the case for investment into funding studies of treatment. But this study really reflected what many of us felt, and that was that calcinosis is commonest in the fingers and hands, shown up here on the left. That was the commonest site. There were over 100 patients participated in the survey, and almost all of them had calcinosis of fingers and hands, about a third calcinosis of the elbows, and then in diminishing numbers after that. But the forearms, which you can tend to lean on a little bit, and the knees were also quite commonly affected by calcinosis. So it tends to occur over pressure points. Next. So now we move on to reasons for having calcinosis and why some people get calcinosis and others don't. So next. Well, unfortunately, we still don't really know what causes calcinosis. There are a lot of different theories, which I'll go through in a minute, but I think it's important to say that it's not related to high blood levels of calcium. And it's thought to be what's called a dystrophic calcinosis, and not a calcinosis that's associated with high blood calcium levels. And that's important because we get a lot of questions about whether people can take calcium supplements, for instance, if they have calcinosis, and I can understand why people worry about that. They think maybe this isn't a good idea because I've got calcinosis and maybe it will get worse. Well, I think you should be reassured that it doesn't. You know, nothing to do with calcium levels. So if you need to have calcium supplements, then you should take them. There are a number of possible contributors to calcinosis that we're fairly confident about. One is that we think that poor blood supply is important in contributing to calcinosis. And we also think that mechanical pressure over areas can contribute to calcinosis. And one of the reasons that we think that is the sites that are affected by calcinosis, the knees, the elbows, the fingers, and particularly in the fingers, the thumbs and the index fingers. And of course, these are the two fingers that actually are subject to most trauma and activities of everyday living. And then there is scientific work to suggest that there's some imbalance in the skin and what we call the extracellular matrix between proteins which promote the development of calcinosis and those which inhibit that. So there are a number of different things which contribute. And there is ongoing research to try and find more out about it, because of course, if we understand more about the underlying disease mechanisms, then that increases our chances of developing specific treatments which are aimed at these pathways. Next. So here you see some examples of what are called scanning electron microscopy images. And I'm grateful to my colleagues in the Department of Chemistry at the University of Manchester for supplying these, but they're different magnifications. At the top left is the highest magnification, but they're rather nice images, I think, of these calcium-containing salts. And that's what we have. And we know that the lumps differ between patients. Sometimes they're much more soft than others. Sometimes they're very hard. And there's a big spectrum of calcinosis. But this is an example of calcinosis from one lump of excised calcium. So they're calcium-containing salts, particularly a salt called hydroxyapatite. Okay, next, Felicia. So we don't really know why some people develop calcinosis and others don't. But we do know that there are certain factors which put people with scleroderma at increased risk of having calcinosis. And these are pieces of a jigsaw puzzle. They're not all or none. But some of you will be aware that we tend to measure a number of different autoantibodies. These are proteins. a special type of protein in the blood, antibodies in people with scleroderma, because they're different autoantibodies, and in a way they're helpful to us because they tend to associate with different disease characteristics. And we know that people who have an anti-centromere antibody or an anti-PMSCL antibody are a little bit at increased risk of calcinosis. Whereas conversely, if you have an anti-SCL70 antibody, which is sometimes called anti-topoisomerase antibody, and I know these are big fancy words, but they're antibodies that we look at a lot, then you are slightly reduced risk of getting calcinosis, although you're not completely exempt. The other thing we know is that people with finger ulcers are more likely to have calcinosis. And we do know, because many studies have shown this, we do know that the longer you have scleroderma, the more likely you are to develop calcinosis. Calcinosis tends to be something which develops later in the disease, although that doesn't always happen. And in fact, sometimes calcinosis is a presenting feature. And there are 1 or 2 studies which suggest that there's an association with osteoporosis. Next, please. Okay, so now we go on to the impact. You know, how does calcinosis affect people? And of course, we've seen the photograph already of that thumb, and we can see that that would be difficult for that individual to bend their thumb properly. So can we have the next slide, please, Alicia? So we're very grateful again to SR UK for running this survey, because I think that provided a good insight for us into the impact of calcinosis, because this is something that we suspected as clinicians and doctors who see people with scleroderma, but it's much more important to know, you know, how you all feel about the calcinosis and how it impacts. And this survey confirmed the impression that calcinosis can have a very major impact. Because of those who responded, almost everyone said that calcinosis was painful and uncomfortable. Over half suggested that there was actual physical impairment. For example, hand function could be impaired with calcinosis. And I'm sure that that will resonate with many of you, because if you have lumps of calcium in your hands, it can be very difficult for you, and particularly the fingertips tend to be affected. And of course, if you're using a keyboard or using cutlery or any of these things, then this can be very difficult, you know, when you have these painful lumps of your fingers. And almost half reported disfigurement and an impact on appearance. I think this shouldn't be underestimated, because of course, calcinosis we've just seen often occurs in the hands, and we communicate through our hands. If you have lumps in your hands, or if there have been, or if you have dressings in your hands because there's been some ulceration, which I'll come to in a minute, then these things are unpleasant, and we understand that. So I think these things are disfiguring, and possibly help to explain why over a third of respondents to the survey said that the calcinosis areas impacted on their mental well-being. When we asked in the survey for respondents to grade on a 0 to 10 scale, 10 being the most severe interference, how much calcinosis interfered with their daily activities, then as you can see here, 70%, so that's over 2/3, reported a substantial interference, you know, of 5 or above. And in fact, 1/3 reported really very major interference, and that was rating at 7 or above. Okay, next slide. And another way in for which the calcinosis impacts for a whole load of different reasons is that the calcium lumps can, as many of you know only too well, they can actually break through skin. And that's perhaps not surprising if you remember that first picture of the thumb, because it creates tension in the skin, the lumps, which are just underneath the skin, and the calcinosis can break through. And while some people actually are quite pleased when that happens, because it can debulk the calcinosis, it can become quite a problem, because you then have an area that can become infected. For example, in the thumb on the right, this picture was taken a little bit later, but there had been infection of the thumb. And the picture on the right is actually a picture of a knee. which had actually a large area of calcinosis over the line of the knee, and really was very unpleasant because it broke through the skin, and the skin then got very infected. And we had to ask the orthopedic surgeons to wash out the affected area. And this can be a big problem, and the areas can become chronically infected, and can become very difficult to manage. Okay, next slide, please. Okay, so now I want to talk about measurement of calcinosis. Now, this might sound a little bit boring, measuring calcinosis, but it's actually very important. Because again, as I'm going to discuss, and as many of you know only too well, we don't have an effective treatment for calcinosis, and we need to develop one. And when you're developing new treatments, then it's very important to have a mechanism of measuring, what we're trying to treat. Because if you don't, then you can't prove efficacy of whatever new medication you're trying. So this is an important area. So next. So calcinosis has been a very neglected area in medical research up until fairly recently. So it's good that there have been quite a few recent studies looking at measurement and other aspects of calcinosis. So I think there is increasing interest. So I think that's good. It's very difficult to measure calcinosis. You can understand that. I mean, how are we going to measure, whether one of these lesions is getting better or not? And so you can use a number of questionnaires. For example, you could measure pain, although that's often difficult because pain can come, again, as many of you know only too well, in the hands from other things other than calcinosis, and can be rather difficult to separate out the different things. But you can have a pain questionnaire, or you could have a visual analog scale asking for burden of questionnaire of calcinosis. But of course, these things are a little bit difficult, and they're very subjective, but that is, a reasonable way of measuring things. But clinical imaging could be a way forward. And I'm going to run through a few of these. I'm going to talk a little bit about X-rays and about CT imaging, or computed tomography imaging, because I think you can measure calcinosis with these techniques. Ultrasound has attracted a bit of interest. You can see calcinosis lumps with ultrasound, but ultrasound is a little bit observer dependent, so that's one problem with it. And magnetic resonance imaging is another way, but it's a little bit more complicated for calcinosis. So the next slide, please, Jose. So this just shows X-rays of the hands, and I think gives you an insight into how we might be able to measure things, because on the left-hand side, you see calcinosis of the right thumb, extending down the thumb, and also a bit at the tip of the right index finger on X-rays. And you can see there that plain radiographs, plain X-rays, beautifully visualize calcinosis. And in fact, if you're not sure whether a lump is due to calcinosis, if your doctor's not sure if it's a calcinosis or a lump or not, that's a very simple matter, because you just need to X-ray it. And calcinosis is what we call radiopaque. So it will show very obviously on an X-ray. And this patient on the left-hand side has a tiny bit of calcium. I'm sorry that I can't use the pointer because I'm not screen sharing, but there's a tiny lump of calcium in the left thumb as well, and a little bit in the left index finger, but most of it is in the right thumb and index finger. And if you look to a year later, then you can see that this calcinosis has got larger. There's a lot more calcinosis in the thumb, and there's a lot more calcinosis in the index finger. So over the course of a year, this has really progressed quite rapidly, and you can now see quite a bit of calcium at the tip of the left index finger. So you can see. So what would be nice would be able to put some sort of number on that and be able to say, well, it's increased by such and such an amount, or hopefully conversely, if we had an effective treatment, that it was going in the other direction. So can we have the next one? So this is a radiographic scoring system that I was involved with about 7 years ago. And this was a group of international researchers under a network called the Scleroderma Clinical Trials Consortium, who developed a scoring system for measuring calcinosis of the hands. It's a little bit complicated, and I won't go through it completely, but basically the hands were divided into 22 areas, and we looked at the area affected, the density of the calcinosis, and there was different weighting for different areas. And we came up with a way of actually measuring calcinosis, which has been shown to be fairly reliable. So I think this will be a way forward for clinical trials looking at calcinosis of the hand. So I think progress is being made a little bit there. And the next slide. And this is, as well, obviously a three-part figure. And this shows the calcinosis on the left, a photograph. And I know it's not a very nice picture, but it does show the problem of calcinosis. Because this patient has very marked calcinosis of the thumb. And you can see this. The thumb is hugely swollen, and you can probably see at the tip of the thumb, these white areas showing through, and that's all calcium. And you can see that it's extending down the thumb, even just looking at the photograph. And of course, this thumb will be very difficult to bend if it bends at all. And then the calcinosis of the index finger, that's the finger next to the thumb. You can see we've enlarged the area at the tip because it's really quite nasty because it's ulcerated through skin, and you can see this white coming through it. And many of you will know that you can get discharge of sort of toothpaste-like material with calcinosis, and that's what happened here. And this patient's also got calcinosis. You can see that at the tip of the middle finger. And you can see all these things in the middle picture with a plain radiograph. And you can see the calcinosis very well there. And we undertook a study, and one or two of you here, I think, probably participated in it a few years ago at Salford Royal, looking at different types of imaging. And one was a plain X-ray, and one was a CT scan shown on the right. And we also looked at MR imaging. And the advantage of CT, although it's not shown in this particular view, is that it's three-dimensional. So you can actually measure volume of calcinosis. And so that's an important addition because, of course, the plain X-ray just looks at it in 2 dimensions. And if you angle the view, then maybe the dimensions will change. But in fact, from this study, we found that there was a very good correlation between the volume on CT and the area on the plain X-ray. So I think that was an important finding because although I think CT does add additional information, it involves quite a lot of radiation on CT scan, perhaps not so much for the hands, but you have to be a little bit careful about that. But maybe for a clinical trial, we could use CT. But in fact, plain radiography is probably, almost as good for following calcinosis. So I think that's a good proof of concept. And I think that's probably what we would use in most studies moving forwards. Okay, next, Lizzie. So finally, and of course, this is the million-dollar question, how do we treat it and can we treat it? And I'm afraid that I have to be absolutely open with all of you that there isn't particularly good news at the moment here. And can we have the next slide? And we don't have a good treatment at the moment for calcinosis. And this seems such a shame because it seems such an obviously visible thing. It's so near the surface of the body. You'd think that you would be able to treat it, but it's proved very complicated, and over the years there have been loads of reports, suggesting one thing or another for calcinosis, but unfortunately, none of them have actually been of proven efficacy. Just occasionally, calcinosis can get better spontaneously because it can extrude through skin, and I think you have to be a little bit careful about reading individual reports of calcinosis getting better. But I think the bottom line is that there isn't any dramatic cure, although there are some treatments that are a little bit promising that need to be explored. But I think at the present moment, pending a cure, the mainstay of treatment is to stress that if any of the calcinosis areas that you might have gets red looking or angry, then you must seek medical advice because the calcinosis could have become infected. Maybe not, maybe it's just a chemical irritation from some of these crystals being shed into the skin, but you have to worry that it's infected, especially if it's ulcerated. And you can get into a big mess of calcinosis that becomes infected, so it's important to get early antibiotic treatment. I think painkillers are important because, as we saw from the survey result, calcinosis lumps are very often painful. And we could consider surgery. Now, you have to be a little bit careful about surgery, and the bottom pictures show surgery of the elbow before and after. This was a big lump of calcium, and there were problems with recurrent infections. You can see in the elbow X-ray in the middle that there's a large area, very large area of calcinosis. And the surgeons did what we call debulk the calcinosis. You have to be aware that surgery will never completely remove calcinosis. It will only reduce its mass. And the calcinosis can regrow. So it's not a cure. But having said that, in certain situations, it can be helpful. And you have to just be careful. And at Salford, it's very good because they're a very experienced hand surgical team. But I think surgery of the hands, as many of you know, in scleroderma is fraught with risk. So I think that you have to, be very careful about surgery. But having said that, it does have a role. And some people are very pleased with the results of surgery. And so it is part of the treatment package, or at least it can be, in carefully selected situations. So next slide. So these are the different points that we've discussed. We've talked about what calcinosis is, how common it is, causes, why do some develop calcinosis and not, how does it affect people on a day-to-day basis, how do we measure it, and how do we treat it? And next slide. So I think there are a number of challenges for us to try to confront the issues. And as I said earlier, there is now more ongoing research into calcinosis. If you looked up the medical literature 15 years ago, you would have found almost nothing on calcinosis. And while there still isn't a huge amount, there's an awful lot more than there was. So I think people are beginning to take an interest in it and realize just what a problem it is. So I think we need to understand more about the underlying mechanisms of calcinosis, because that will allow us to develop new treatments. We need to develop, and I spent a little bit of time talking about that, ways of measuring calcinosis, because in that way we'll be able to run treatment trials when we have appropriate drugs. And we need to develop new treatments. And I'm going off a little bit at a tangent, but at the University of Manchester, we've been very interested in trying to identify compounds which might dissolve calcinosis, because it is a very superficial problem in that it's superficial to the skin. And so wouldn't it be wonderful if we had some sort of topical treatment? Topical means applied locally, for example, rubbing on like a cream or an ointment. And it would be really good if you could have something that you could apply topically. And we've done a lot of research on this. This research was funded by SRUK, to whom we're very grateful, and more recently by Versus Arthritis, who I think recognised that this was a very important problem. So we were delighted when they funded this research. And this just shows one of the slides from my science colleagues at the University of Manchester, showing that citric acid was a compound which was able actually to dissolve calcinosis. So we're hoping to take this work forward, but unfortunately, clinical trials and people, which is the next step for us, are very expensive, and it's very difficult to identify funding for them. But we are in the process of doing that, because that's what we want to do now. We want to do a clinical trial looking at these topical treatments for calcinosis. So next slide. So just my last slide is just to conclude. The calcinosis is common, as many of you know only too well, in people with scleroderma, and it causes a lot of pain and disability. As I said, it's been neglected in research terms, but this is being addressed. And at the moment, the most important things you can do if you have calcinosis are to keep an eye out for a lesion becoming infected and try and treat it early. Painkillers as necessary, and consider perhaps surgical debulking, but that's not appropriate in a lot of cases, but it is in some, so it is something to be considered. And as mentioned, we're hoping to continue our research and hopefully find a solution to this very major problem. So thank you very much, Lucy, and I apologize again that for some reason the slides didn't want to migrate forwards. And thank you to SRUK.
Well, thank you so much. That was a very interesting presentation when we got the tech working. We have had a few questions through already. If you do have any questions, put them in the Q&A box and we'll do our best to get through them all. Oh God, there are more coming in already. So given the significant impact of calcinosis can have on people's mental health, what, if any, support is offered in this context?
Yeah, well, thanks for the question. This is obviously a very general question for support of individuals with a disease like scleroderma who have problems with various manifestations. And I'm afraid from the point of view of support, I assume that we're talking about, for example, clinical psychology support, etc. That's very that's rather dependent on the local support, really. So I wouldn't be able to give a general statement about that. I think different hospitals and different care organisations do have different, some of them have very good access to psychological support, but others is more difficult.
Thank you. Next question. Is it bad to use support socks or stockings if you have calcinosis in the lower legs? I need to use support socks because of leg ulcers. My doctor and I have discussed this in regards to pressure and maybe less oxygen in the smaller superficial blood vessels.
I don't think there's any evidence that support stockings would help, but I don't think per se it would be bad for calcinosis. I think any support stocking, it's always important if you wear support stockings that they don't overcompress the blood supply to a limb. And that really applies for anyone. And I'm not, so we would never be advocating a support stocking that would compromise blood supply. So for that reason, I don't think it's particularly relevant as to whether one has or has not got calcinosis. So I hope that answers the question.
Next question. Is it possible to develop calcinosis in the Achilles tendon? I'm a keen hill walker and skier. Wearing boots is a big problem, causing pain, and physiotherapy hasn't helped.
It would be possible to have calcinosis over the ankle area. I think essentially you can see calcinosis at a whole load of different areas. You just need to check whether it was systemic sclerosis related calcinosis. But if it was, the answer is yes, it could occur around the ankle calcinosis.
Next we have, do you think that bad circulation has a part to play in this problem? Could exercise help?
I think exercise is always good, within one's limitations. There's no scientific evidence to suggest that exercise would actually positively help calcinosis, but that would be a tremendously difficult thing to ever prove. And I think the main thing is just to be sensible and keep active, and I think that's right. I'm afraid I can't promise that exercising will help calcinosis, but a good idea to do some exercise anyway.
So I think that's one that comes up in a lot of our webinars, to which the answer is always, if you can exercise it, it won't hurt to add it in, whether we have proof or not, that it will help specific problems. Our next question is possibly a bit more open. Since being on cyclical ABX for systemic sclerosis gut symptoms, I haven't had an infection in breakthrough calcinosis. I don't think the link is coincidental. What do you think?
Okay, well, I'm delighted to hear that cyclical antibiotics may have helped. It's very difficult to know, and I think that probably it's difficult to generalize. I think some individuals have chronically infected calcinosis, as I think I maybe mentioned earlier, and perhaps for that reason, if you are on antibiotics for another reason, then that may have an unintended consequence that actually helps the calcinosis, in that you'll perhaps have fewer flares. This has never been sort of scientifically proven, or examined, but I can see that could be an explanation. I mean, some of you will know that minocycline has been looked at in calcinosis and has been suggested to be helpful. Some comparative recent work from the Royal Free has suggested that. It's a little bit difficult to know about that, but minocycline could be exerting its effect in different ways. But there is some evidence in support of that. But not such sufficiently firm evidence that we could say that it was a curative treatment, but perhaps something to be considered.
Thank you. I've had lots of comments saying thank you, and it was a super interesting presentation. Another question: are topical painkillers like Voltarol any better than oral medication?
It's an interesting point. You know, I don't know of any work that's looked at topical non-steroidals, Voltarol's non-steroidal, specifically in areas of calcinosis. And again, it would be a rather difficult study to do. But, you know, if it's helpful, then as long as you just need to be a little bit careful that about applying it to skin, as long as it was intact skin, then I see no reason why one shouldn't apply it. I think the advantages of topical painkillers over oral ones are that they may be less likely to cause what we call systemic side effects, you know, because the dosage is lower and it's applied to where you need it. So there would be a rationale for topical anti-inflammatory, especially if there was some inflammation there. But I can't give you a direct answer to the question, I'm afraid.
Okay, next question. How do you heal the area after calcinosis? This person says, calcinosis came out last September and I still have an open wound which won't heal. I'm worried about infection and wear a plaster most days.
Yeah, so I'm sorry to hear that. And there has been some work, and it is well recognized that ulcers over areas of calcinosis are slower to heal than ulcers which aren't associated with calcinosis. And I think it's a problem. And, you know, because you can see in one or two of the pictures that I showed, you know, there's the skin is stretched over the calcinosis and it's difficult for it to heal. And unfortunately, I think all we can say is that it's important to have very good specialist nursing care. And certainly it would be important for someone with calcinosis and a significant wound to have that level of nursing care, and perhaps with involvement of the tissue viability team. But there isn't any, unfortunately, there isn't any sort of specific thing other than just all the usual tissue viability recommendations, really. But it is a not uncommon experience that calcinosis wounds are very difficult to heal.
That sounds frustrating all round. The next question is, could you explain the difference between debridement and debulking?
Well, it's interesting. We probably use them a little bit interchangeably. I think debulk simply means reduce the bulk. I think debridement maybe, to me, I think you maybe should ask a surgeon for a definition and probably say I wasn't giving you the correct answer. But I think from debridement, I would understand a sort of cleaning up, which may or may not involve a debulking. You know, it's just a removing of dead tissue and so forth. So I think it's probably, in the context of calcinosis, it probably, most people would probably use the term more or less interchangeably.
That's good to know for the future, isn't it? Next one. I have osteoporosis and have broken bones, which were missed because calcinosis masked it on the X-ray. On one occasion, I was refused an MRI, so another time I didn't present to A&E. How do I go about asking?
Well, again, I'm sorry that you've had that experience, and it's a difficult area. But there's absolutely no doubt, and you saw the X-rays, that if you have a great big lump of calcium, it's going to be very difficult sometimes to see a fracture line beneath that. So I think it's important, if you have that anxiety, then I think it's just it's just important to raise that anxiety with the casualty officer or the surgeon that you see, or whoever you see in the emergency department, and just say, look, you have this, you've had this experience in the past, and you're concerned that there's a fracture. Because an MR will almost certainly demonstrate a fracture. And, you know, I think, to be fair, it's a little bit difficult sometimes for people to have a good understanding of scleroderma. It is a rare disease. And I think sometimes it's to be encouraged that you raise your concerns and you know, because you'll almost certainly know more about calcinosis and scleroderma than some of the other people that you will meet. So I would specifically ask, would an MR be helpful if I was in that situation again?
Great. Next question. Are soft areas of calcinosis likely to stay soft over time or become more troublesome?
Well, that's a good question. It's a very interesting question. And it's always been my belief, although I might be quite wrong, that areas often start out as soft, and certainly the larger ones, and then they eventually become harder over time. So I don't think we know the answer to that question, but there's no doubt that some lesions do seem to start off as soft and fluctuant and sometimes discharge, and then maybe a few months down the line, there's a hard lump. So I suspect that they eventually solidify over time.
Next question. Can calcinosis reabsorb internally? I've had lumps on my knee and elbow that appear to have resolved themselves.
Well, that's interesting, and I'm delighted that they did. And this is what we're told, and by some that they do seem to get less, and so I think it must be possible for them occasionally to resorb spontaneously. I mean, perhaps especially when they're a bit smaller. Again, it seems a very easy question to answer, but it isn't. And it's only very recently that we've begun to see studies which follow calcinosis over time. Nobody's really looked, well, there has been one study comparatively recently looking at calcinosis and several lesions over a 12-month period, which was great because people are beginning to study these things, what we call prospectively. And in that study, some of the lesions did get less. So I think it is perhaps possible that they can resorb. It's certainly possible, as I said earlier, that they can extrude and sort of debulk themselves in that way. But I think it probably is possible that they resorb. And that's one of the reasons why we always need to be a little bit careful about the reports of improvement with calcinosis, because I suspect that sometimes they do resorb a little bit themselves, although unfortunately we can't promise that. Perhaps the earlier, less hard lesions.
Really interesting. How do I stop the deposits leaking? So next question.
Well, again, all these simple questions are the hardest to answer. And I think some areas, unfortunately, do leak for a long time, and that's obviously very distressing. I think if there's a very large area that's persistently leaking, and especially if sometimes you're getting infections in it, then I think that's the time to maybe specifically ask your doctor if it might be a good idea to consider surgery, because perhaps there might be a role for debulking the lesion in that case. I can't obviously comment on an individual case, but just talking generally, if there's a persistently leaky area, then you might need to consider that. But surgery can be fraught with problems as well, and it may well not be appropriate. And I think all you can do is just try to keep the lesion as clean as possible, so that there isn't an infection, and hope that eventually it will dry. But I don't have a good answer to that. I'm sorry that I don't have answers to these questions, because they're all very good questions, and I understand how distressing it must be.
Thank you. Can calcinosis occur under your nails, and if so, how can I treat it?
Calcinosis I have seen calcinosis quite frequently involving a lot of the area, just beneath the nail, but at the tip of the nail, at the tip of the finger. I'm not sure that I've ever actually seen calcinosis pressing up underneath a nail, but I have seen it around the tip of the finger, spreading downwards. So by definition, it would be slightly underneath the tip of the nail. And again, if that was a problem, you may need to ask for a surgical opinion on that, I think.
Okay, next question. How can I tell the difference between calcinosis and infected ulcers?
Well, of course, calcinosis can be responsible for ulceration, which can become infected. So you could easily have the two. If you have a finger ulcer and you're not sure whether there's calcinosis underneath it or not, then it can be, and the doctor's not sure, if you prod around it and there's no obvious calcinosis lump, then you know the probabilities are there won't be calcinosis. But if there's any doubt about it, then you can do an X-ray, and you know maybe a specific angle, maybe a lateral view or something, or different views, so that you can definitely see if there's calcium underlying it. It probably doesn't make a lot of difference to the immediate management of the ulcer, because irrespective of why the ulcer is there, you know, the main thing is to have an antibiotic if it's infected, and measures to improve the blood supply and careful wound care. So these things would apply irrespective of whether there was or was not calcium.
Okay, great. Next question is, if I have calcinosis, should I be having regular checks for autoimmune diseases?
Well, that's an interesting question. I think if someone comes along with calcinosis, then it depends a little bit on where it is and whether there's more than one area. And I think it's obviously something to ask your doctor about why you have calcinosis. But you can have calcium containing deposits beneath the skin for a number of different reasons. For example, if you have a very bad bruise, you know, causing a hematoma, if you sort of bash your leg or something, if you have an accident, then you can get calcification in that area afterwards. So the fact that you have calcification certainly doesn't mean that you have an autoimmune disease. But for example, if you were to have a whole lot of calcium lumps at the tips of the fingers, then that would be very suspicious. And sometimes we do see scleroderma presenting in that way. You know, someone will come along with these lumps and someone's realized that they're calcinotic, and we are asked to see them to see whether there might be an underlying systemic sclerosis. So it depends very much on the pattern, but it is something that would always cross our minds. Well, of course, it would always cross a rheumatologist's mind, because that's what we're obviously most interested in.
Thank you. We do have time for a couple more questions, so do keep sending them in if you have them. The next question we have is, I don't want to take medication for calcinosis. Are there any natural ways I can treat it, and would eliminating something like dairy help?
Well, again, I'm sorry that I can't answer the question directly. I'm not aware of any evidence to suggest that any specific dietary restriction would have any influence on calcinosis. You know, there's a lot we don't know about calcinosis, so it's very difficult to exclude these things. I'd be a little bit surprised if eliminating, I mean, I can't think of a scientific rationale for why eliminating dairy products would be helpful. And I think I say this to everyone, I think it's important to have a balanced diet, and for a whole load of reasons. So I'm not sure that I would try that myself, but you know, as I say, no good evidence to support that.
Right. Got a couple more questions in here. Is topical 10% sodium thiosulfate effective?
Well, that's a good question, and thank you for that. And sodium thiosulfate is what we call a chelating agent. You know, that means that it can bind to calcium, and there's been a lot of interest in this compound called sodium thiosulfate as a possible treatment for calcinosis. And there are reports in literature. It can be given in different ways, and one of the ways is to give it, you know, as a topical or local preparation. So there are a few reports in literature, and it is one of the compounds that we looked at in our research in Manchester. So I think it does dissolve calcinosis, but we weren't terribly impressed with it. From the evidence in the literature from sort of human studies, there have been some reports of topical sodium thiosulfate helping, and I know some clinicians use it on a sort of unlicensed basis. So I think it's perhaps worth a try. it has also been recommended in a very small number of anecdotal reports to give it intravenously. And again, you know, that has been tried. My own experience hasn't been particularly, that it's been particularly helpful, and it's a big bind and coming in for a weekly infusion. So I haven't been impressed with the small number of people that I've seen with it. But it's an interesting line of approach. And I'm all for trying topical treatments, but I'm not sure about sodium thiosulfate.
Thank you. Could there be any gut involvement in the formation of calcinosis?
I'm not aware that calcinosis occurs in the gut. I mean, I think calcinosis tends to occur in, you know, the soft tissues beneath the skin and surrounding bony structures. It can occur deeper, but I'm not aware that it would occur in that sense in the gut.
This is probably about our last question for now. Lots of people saying how helpful it's been. So can calcinosis be hereditary? Could I pass it on to my children?
I don't think there's any evidence to suggest that it's hereditary. That opens the broader question of a hereditary component to systemic sclerosis or scleroderma. And yes, there is a hereditary component to scleroderma, but it's very, very low risk to family members. You know, if you have, many of you will know this, but if you have systemic sclerosis, then your risk of a first or degree relative having systemic sclerosis is about 1 to 2%, you know, so that's much higher than the general population. So it is a significantly increased risk, but it's still a very small risk. So then if you extrapolate that down to the risk of getting calcinosis, you know, I think it would become even smaller. So, you know, so maybe there is a slightly increased risk. Well, there is an increased risk of scleroderma in the first instance, but I couldn't comment specifically on within that risk, the risk of calcinosis.
Great. Well, thank you so much. It's been a really interesting webinar. I know we've had a couple of clinicians in the comments asking questions and saying how useful it's been as well for them. So I think a lot of people have learned a lot of things today.
Well, thank you all for the questions. I mean, there are some great questions, and you know, these things make us think, because, and I say, so often the simple questions are the most difficult ones to answer, and yet they're the ones that matter the most. So I'm sorry that there are no solutions, and perhaps in a few years' time we might be a little bit better at giving you a satisfactory answer.